Thank you. And I want to begin by thanking Ivan Shahin and the rest of the organizing committee for giving me this opportunity to join this panel. I feel honored. I also want to mention that I feel a bit amused to be here today and to find myself in the same room as Philippe Couillard, who used to be a classmate. We were both at Collège Stanislas for many years, often in the same class, and several summers played tennis together. Fortunately, we were both better students than tennis players. Well, it's very unusual for someone with my pragmatic economist background to be asked to join a panel of this nature. And I thought I would take this opportunity to share with you some perhaps somewhat radical reflections concerning economic rationality, healthcare policy, and care for people with severe mental illness or other disabilities, reflections that go well beyond what I normally do my research on, but that have been nourished by my research and my work in general. So to introduce this, I will start by talking about economic analysis. And I hope you don't tune me out immediately. Well, in the context of healthcare, what is economic analysis about? Well, it encompasses many kinds of questions, such as what are the consequences for healthcare costs and outcomes of paying physicians on a fee-for-service basis, capitation basis, a salaried basis, or some combination of those? What would be the health consequences of introducing user fees for health services? And what are the benefits in relation to costs of funding particular types of programs for example, people who have severe mental illness? Well, we could get lost in these trees, but if we zoom up, we will see that economics is fundamentally concerned with efficiency. If you put right-leaning and left-leaning economists in the same room, there's one thing I can predict they will all agree on. Wasting resources is stupid. If paying physicians on a salaried basis means they waste more time, then we need to give them economic incentives to achieve more patient benefit per day from their training. If user fees for services that patients tend to overuse help decrease unnecessary consumption, then perhaps they should be introduced. If community-based, assertive community treatment teams can help people with severe mental illness out of the hospital and reduce overall costs to the healthcare system while improving outcomes, then we should implement them, and so on. Although I haven't seen any actual survey results on this, I think it's safe to say that economists have a common passion to avoid waste, not because we hate waste per se, but because eliminating waste means we have more resources available to do other things. But economics necessarily has to be concerned with a lot more than just eliminating waste, because in reality, changes in economic arrangements usually have many consequences, and only rarely do they simply reduce waste. For example, some of you may have wondered about what I said a moment ago about introducing user fees. And rightly so. The RAND health insurance experiment in the United States has shown that people are not very good at discriminating between needed care and unnecessary care. And also that the poor are more sensitive to user fees. So the effects of introducing user fees are by no means unambiguously positive. It's the same in the context of mental health care. For some so-called revolving door patients, assertive community treatment manages to both cut costs and improve outcomes. But for those who are not hospitalized as often, whether because they are in a system where access to hospitalization is not as great, or because they're not as ill, then assertive community treatment may improve outcomes, but at greater cost than before. So how do we decide whether the extra cost is worth the improved outcomes? Complicating things even further, there's evidence that ACT teams are more or less good for the people they serve, depending on how coercive they are, which in turn almost certainly has to do with how much clinical training their staff have. So ACT teams can be expected to improve outcomes to a greater or lesser extent, depending on how much you spend on the teams themselves. But if you spend a lot of resources on ACT teams, what are the consequences for other patients? How do economists propose that we deal with these trade-offs? One can oversimplify by saying there are two schools of thought. One modestly says, we're not competent to make judgments about these trade-offs. That's the job of decision makers. All we should do is make the trade-offs explicit. But the other school responds, well, yes, ultimately it is the decision makers who are going to make those decisions. But we need to give them as much information as possible on which to base their decisions. One useful type of information we can give decision makers is how society as a whole would make those trade-offs. Decision makers may have political or other motives to judge among the trade-offs differently than the rest of the community, but at least they will then have some rational guidance to start from. Well-regarded academic health economists who concern themselves with health economic evaluation tend to be in the second group. But this raises the question, how do health economists determine how society as a whole would make those trade-offs? The key tool, which many of you have heard of or perhaps know very well, is quality-adjusted life years, QALYs. For those of you who aren't familiar with QALYs, I'll just give you a very brief explanation, and this is important to the rest of what I'm going to say. To calculate the QALYs associated with an intervention, you need to determine a health-related quality of life weight for the health state associated with, well, for that health state, which may be altered by the intervention. This weight is equal to 1 for perfect health and 0 for death. Some states are considered worse than death, and so they have negative health states. For example, a recently published survey of veterans in the United States found that veterans with depression had a health-related quality of life weight of 0.54 compared with 0.63 for non-depressed, otherwise comparable veterans. That's a difference of 0.09. If treatment enabled depressed veterans to reach the average health state of their non-depressed peers for 1 year, then this treatment would generate 0.09 times 1 equals 0.09 QALYs. If this treatment costs $1,000, then the cost per QALY gain would be $1,000 divided by 0.09, or basically $11,000 per QALY. This kind of calculation is very commonly done in economic evaluation. It has huge influence in England, where the National Institute for Health and Clinical Excellence, otherwise known as NICE, commissions such calculations and makes decisions on that basis as to which drugs will be funded for which uses. In the UK, the NICE 2 guidelines state that if an intervention has a cost of less than £20,000 per QALY, it should be adopted. More than £30,000 it should not, and in between those two thresholds, it depends on such factors as whether the population affected is disadvantaged. Now, there are a few aspects of this procedure that I would like to remark on,